undertook the review. In June, NHS England, in July, NHS England was asking ICBs to undertake an exercise, which was called a maturity index exercise. So every system had to answer a kind of large survey, which gave a view of how well your policies and practice met the needs of this patient group. For us, it highlighted some areas of further development, which I won't list in full, but it did note, I think specifically, that as a system we required further development of supported accommodation, step up and step down, so people at risk of hospitalisation who could go to a more supported environment, and those who are in hospital stepping out to more supported accommodation. There's some correlation there with some of the patients who are currently delayed on our acute wards, and a rounding out of the staff offer for this group. So specifically, forensic services in the community, peer support, and access to social work. I mean, I think there's an irony in this whole process, I guess, that in 2010, all trusts had assertive outreach teams, every single one. It was a national requirement, and they'd be engaging patients like Colin, who we heard from earlier, but they were natural targets for efficiency and productivity measures, because they're low productivity teams. They're working with caseloads of 10 people per worker, maybe up to 15 at times, and you get a lot of non-attends. As the engagement clinic said, you knock on somebody's door, they're not in, you go again. It's worthwhile, but it's very intensive and it's very expensive. The feedback to NHS England following the everybody submitting their returns was, very few of us have got a dedicated assertive outreach team. If we're going to meet everything on the maturity index return, that's exactly what we're going to need, because everything that's described here in the return adds up to an assertive outreach team. Thankfully, NHS England still contains some people like Nathan Gregory, who worked with us, who wrote the original national guidance. So there's still some people that have got enough organisational memory to understand how the pieces fit together. When we undertook our maturity index review, we reckon that there were about 230 people across Herefordshire and Worcestershire who could benefit from an assertive outreach approach. And we made a submission based on offering a full assertive outreach team style approach to those who don't currently receive it. So that's we put in a submission for £3.2 million. I've checked with some other trusts. That's actually quite a modest amount. We've put it in to be ambitious but realistic. So if we get all of that, we will have a very, very good assertive outreach approach being able to be offered in Herefordshire and Worcestershire. It excludes capital. We've identified in the bid that we'd require capital as well for building leasing as well. Our local position in terms of how well we're delivering to this patient group at the moment, it's a mitigated approach. So we've got an assertive outreach team in Herefordshire that does everything an assertive outreach team should do. Probably requires a bit of further development, a bit of modernisation, a bit of adjustment to meet the exact profile of the needs in Herefordshire, but it does a good solid job. In Worcestershire, we've set up engagement clinics. These were set up before we received the highlight report, so they were resultant actually from some work that we've been doing for a few years around the psychosis pathway, and we've got those set up for 4 out of 7 teams at the moment. Just for some reassurance as well, I wouldn't say assurance, but it's reassurance, we don't discharge none engaging patients with difficult severe mental illness histories. It's not something we'd do. One of the challenges in Nottinghamshire, and something that happened that originated the very first set of outreach teams back 20, 30 years ago, was that where people who were difficult to engage weren't coming to appointments, eventually they get discharged. On the basis that this guy doesn't want a mental health service. But that's not the way to think about people that have severe risks associated with psychosis, and we don't. But we're reviewing local protocols to ensure that that's absolutely baked in, to say this is our policy, we do not do that. It's not our practice, but it's not probably explicit enough in our policy. We've started a program group locally as well between the ICB and ourselves, and that's now supported by the Trust PMO as well. We expect to hear back before Christmas from NHS England about our bid. It may be expedited. There was another mental health killing in Manchester this week. Obviously, we don't know the full details of that yet, but I guess that kind of issue keeps this very live in NHSE's mind.
Thank you, Matthew. And that's for everybody's information to ensure you're aware of where we are. I suppose it's worth reiterating that these things only happen because of some tragic cases around the country, as we've actually seen. Robert.
Yeah, thanks, Mark. Probably worth just drawing out the governance in the system around this, because clearly it's a really important issue. As Matthew said, this actually provides an update to our board around where we are. The formal process around this is up through Mental Health Collab Joint Committee and then through the ICB board. So clearly what this report doesn't provide is the action plan, because we're still working that through. And the expectation is that by the turn of this year, so the ICB board in January, that we're able to take through there the findings, the information Matthew's talked about, and the worked up action plan. So that's probably just an important part for everyone to be aware of. That kind of is the governance part that we go through. And clearly for us, that goes up through Mental Health Collab Exec and then the Joint Committee and into there. So Sue is very much involved with that and working with Richard Keeble to make sure we tie that up clearly with Matthew and team as well. But the final action plan, I suppose I should just draw out, it's in the report. There are more elements to the response than just the services we provide. So there will be other aspects. Sue, I don't know if you wanted to just draw some of those parts out for.
Yeah, Robert, that's fine. So yes, there's expectations around this agenda that sits in primary care and the voluntary sector. It's a natural overlay with the police and local authority, and they're all round the table for the Mental Health Collab Exec. So that feels like the right place to make sure that we're all pulling in the same direction and aligning our plans. That'll come out in the actions, and that'll be part of the conversation as we move through the Collab Exec, say overseen then by the committee. Probably just also noting that this has got an alignment with all the work we're doing on inpatient and rehab. So we're looking to have the PMO over all of this agenda and bring it all through quarterly so you can see the interdependencies, but then each one will be monitored monthly through PMB.
Okay, thank you, Sue. Thank you, Matthew. Obviously, we're with eager anticipation waiting to see if there are any funds that forthcoming to address this, and I know that Robert and yourselves will bring it through if they do. Can we note that report, please? Thank you. And we'll move, Natalie, a quick update on vaccinations.
Yeah, so this is just a report to demonstrate how we're approaching the winter vaccine programme for our staff, which is the flu and the COVID vaccine. So across both counties, we've partnered with pharmacies and other organisations to ensure that we've got mobile clinics available across the two counties, including out of hours, as well as our staff providing a local staff vaccination service walkabouts to maximise uptake. The other most significant change to note is that there's no national sequin, so there's no target for percentage of staff to be vaccinated this year. That's switched to a request that we offer all staff a vaccination, so that's 100% offer of a vaccine as opposed to the uptake of a vaccine. That's quite a significant shift nationally.
Thank you, Natalie. Janet?
Yes, yeah, thank you, Mark. Thank you, Natalie. My question was about the fact that we seem to be hearing a lot of reports about people having vaccine fatigue and you know, thinking that actually they've been vaccinated and aren't coming forward. So I just wondered, is that something we're seeing among our staff, and what are we doing about it?
I think there's two factors at play, Janet. The mandating of the COVID vaccine was seriously damaging to vaccination programmes for staff uptake, and we've never recovered the position nationally since then. So we've got a really, you know, that caused significant damage. We are actively promoting both vaccines. We do lots of myth busting. We have lots of general conversations. We encourage uptake as much as possible. It's just really important that we have a compassionate response to that, as opposed to a mandating approach, which will see lower uptake rates.
Thank you. If there are no other questions, I know board was all had vaccine available to them at our last meeting, Natalie, and I think it has been seen with you with a syringe in your hand, I understand. Indeed. On occasion. So you can see how seriously we take it when the Chief Nursing Officer is part of the vaccine uptake. So thank you. If we can note that report. And when will we next hear through board, Natalie, or can Jill, because I know we have to report through our final position. When will that be, please?
So through board, we'll hear early spring. So the vaccine campaign closes at the end of February officially, and then we just assimilate the results.
Thank you very much indeed. Okay, we now move on through to our normal performance and committee reports, perhaps more standard items. And we'll go through them in the normal order. So first of all, it's quality and safety. Janet?
Yeah, thank you, Mark. I think this is the second time, or possibly the third time, we've presented our report in this fashion. Maybe it's the second. So I'll just pick out with the items for alert, advice, assure and achievements, which is the format that's being used through the integrated governance system, and how we're getting the reports to the committee. So I'll just pick out a few of the items. Obviously we've got the regulation 28 from the coroner, and I think the important thing that we've picked out there is around the learning with all these things, and around how patients, you know, fall between system partners and communication processes to try and avoid that. Under the advise section, a couple of things I wanted to pick out there. One was the fact that actually the risk summit approach is really useful, and that we found now that some of the neighbourhood teams are using that approach locally to manage issues that they're coming across. The second one was around lone working, and the fact that a couple of the SDUs are highlighting the need for lone working devices. But what we had questions about that in the committee, and what that's actually leading to is actually looking at the whole process of supporting staff who are working on their own in the community, and recognition that actually there's more to that than just giving people devices. You need to have the system around that. And ensure people are working safely. So work is ongoing in that respect. Then I wanted to pick out quite a long debate that we had around the CQC must-dos. We've had the action plan, the improvement plan from Scott, and that's come to QNS and come to board around the CQC report. But in addition to that, we had a list of must-do actions that we had to complete. These are actions without a timescale to them, and the Trust works very closely with the CQC in actually looking at how they're done and what's being achieved. And this process has actually been, what we've decided to do is not go through a tick box and just do this in a simplistic way, but actually try and ensure that we actually look at what's behind the must-do action, and we look at actions that are going to address what's behind there, and looking to see what impact we've got. And the team have developed I suppose a pro forma to actually ensure that that's happened for all the must-do actions. what this has meant is that maybe we're not getting through them as quickly as possibly we'd anticipated. But actually we're getting assurance that the process that's being followed is thorough, and that the impact is being monitored. So we did have a debate about this. We signed off one of the pro formas, which was around the use of freedom to speak up, the process and the guardians, and we're anticipating that those will continue to come through the committee going forward. The final thing I wanted to pick out is some of our achievements as well, because I think it's really easy in a Q&S meeting, and particularly looking at the integrated governance process, to actually focus on the areas where we have challenges, and that's important, and we should do that. But I think it's also important that we look at our achievements. And the couple that I wanted to pick out were the fact that actually a new EPR has been rolled out in the dental service, somewhere that's quite close to my heart, and that's been very successful, and there's been a lot of learning from that. And I've interrogated people in the dental service about that, and it really has seemed to gone very well indeed. And I think that's actually quite reassuring when we look at the rollout of the wider EPR, to know that actually we've got learning in this service that can be used, and that our processes are working. And then I also wanted to pick out the fact that the Learning Disability New to Care project was a finalist in the Nursing Times Award, because I think that again is something really quite significant nationally and significant for the service. So those are the items I wanted to pick out. I know we've got the actual quality report as well, which Natalie will take, but happy to take any questions.
Shall we move through the quality report and take questions on both together? Would that be okay, Janet?
Really sensible. Thank you, Mark.
Wow. Not often accused of being that. Thank you. Natalie.
Yeah, so I'll summarise briefly under the three main pillars of patient safety and quality. So under patient safety, just to note the concerns for staff in relation to how we record pressure ulcer. There's a change to the national reporting, particularly under PSERF, where we used to not report if it was a pressure ulcer not attributable to our care. Obviously, PSERF isn't about whose errors are attributable to which service. So we now have to record all pressure ulcers, but there's a working group looking at that. Thinking about effectiveness, we are 6 months into the NACEL audit, which is the end of life care audit, and we've already got some rich learning there, particularly about how we approach hydration and spiritual care that we are implementing with the teams. And the clinical policies group is making really good progress of updating clinical policies, clinical stops, and making sure they're aligned with an equality impact assessment. So they're motoring through those now with really good compliance. Patient experience, I want to draw out our response rate is now at 94% compliant with the timescales, which is a significantly improved position from where it was 12 months ago. So we're now moving into the quality aspect to making sure that they are of high standard. Easier to read is one of the feedbacks we have. And also we've drawn our complaints team into our learning and improvement forum, so that we are now triangulating issues from patient safety incidents as well as complaints, and then how we spread that learning across the organisation. Our work with care opinion continues, and you've got a nice dashboard there demonstrating the use of care opinion. It's definitely proving more challenging in mental health than it was in physical health to get stories. A couple of teams have already adapted a process and have co-produced experience tools by themselves, so we'll continue to use lots of varieties of getting feedback from patients. And the culture of care work has commenced in our older adult mental health wards, and the team are supporting that, in particular how we use experts by experience across the organisation. And finally, regulated compliance. We're delighted we now have a dedicated role within our safety team. So they're now leading the CQC must do work, and our CQC engagement work continues. And as Robert alluded to, we've also been chosen as one of the provider organisations to pilot a new format of engaging with the CQC regularly with a nationally mandated agenda. So we'll yet have our first meeting. And that's my updates.
Thank you, Natalie. Thank you, Janet. Anybody got any points that they wish to raise on that? I certainly think the reports are now far more succinct, that allow us to immediately hone in on the information that we get. So thank you for that. Nothing. I've got one point, can somebody please update on the Hillcrest move, please? I notice we do have a fantastic history now of moving our mental health wards in both Stonebow and Elgar. Really effective, really efficient and quietly done, and it's not an easy thing to do, but I understand that our Hillcrest move is to take place shortly. Could somebody please indicate the time frame, please? Matthew, is it?
Yes.
Matthew, thank you, Matthew.
We're booked to move on the 3rd of December. We had previously wanted to move on the 19th of January, but we couldn't get. We had some problems with the removals company that we were moving, so we've had to change the date.
A simple explanation for delay, which we can all relate to. Thank you, Matthew, and good luck to you and the team with that. I know it's not easy doing it, but you seem to do it and complete it quite well. Thank you. If we could note those 2 reports, then please. Thank you, and move on to the report on Workforce Committee. We'll kick off with Vina, then I suspect there'll be, whether it be Natalie or Naomi, weighing in with assistance. Vina.
Thank you, Mark. I'll take the paper as read and highlight a couple of key points from our committee meeting, if that's okay. I think I mentioned earlier that this was we had a staff story, and actually this was the first time in many months that we've been able to make the time to start with the staff story, and it was a reminder of how important and useful they are. We heard from Alison Want, a Deputy Associate Director of the Trust, who put forward a really articulate and compelling case for prioritising the use of a mediation approach when we address staff concerns. And Scott explained earlier that the implementation of the resolution policy has been delayed somewhat, and I think we were all a little over-ambitious about trying to amalgamate all the different policies relating to grievances, behaviours, absence, performance into one. You know, that was a mammoth task, and we've realised that we need to introduce the resolution approach in stages. And we've questioned which aspect should be prioritised, and it does make sense to start with how we deal with grievances and staff concerns, because if we're able to resolve those issues through approaches like mediation, it may well prevent or at least reduce the need to formally address absences and behaviours. So Alison's story and all the brilliant work that she's done in that arena was a really powerful reminder of that. In relation to workforce metrics, i.e. appraisals, turnover, leaver discussions, they remain largely unchanged, and I think Naomi is going to be talking through some of that detail. I will just make the point that the data continues to show us that we are operating, and actually all the numerous initiatives that we've introduced, the way we're operating don't really appear to be having an impact on those metrics, hence the need for the reset in the way we work as a committee. We feel that our proposed reset, which includes a change in the name from Workforce Committee to People and Culture, better reflects a shift in our focus and values in a couple of specific ways. The term workforce tends to focus on the operational or staffing aspect of an organisation, which can give a more transactional or task-orientated impression. We think that renaming what we do to People and Culture embodies a much broader perspective, which includes not just staffing levels, but actually the well-being, development and engagement of individuals within the trust. We really want to focus on individuals, not just as employees, and ultimately we want to foster a much more inclusive and supportive work environment. I think if Elaine was here, she'd be able to do this much more eloquently. And we also want to emphasise that organisational culture piece by renaming the committee and actually creating a specific subcommittee to focus on culture. We're signalling a real commitment to fostering that positive organisational culture, which we know is a really critical factor in the success and sustainability of our teams. And finally, I think we want to see a shift from just compliance to genuine engagement. The word workforce can sometimes imply a more compliance-driven, resource-based view of staff, I think. And what we're trying to achieve is a more proactive, people-centred approach. Focusing on that employee engagement, satisfaction, empowerment. And we know from our last staff survey that we didn't score particularly well in those areas. And we want our staff to know that we've taken notice and we want to do something about it. So in terms of our committee reset, our proposal is to reorganise the way we work so that we have 3 subcommittees to specifically focus on EDI, culture, attraction and recruitment, to enable us to give the depth of focus and discussion that I don't think we've always had the time to do in the current setup. I think Naomi's going to explain a bit more in terms of the detail of that, but I will say that as a stepping stone to that refocus, we had an additional extraordinary meeting yesterday to discuss where we're at in terms of the EDIE work, and how the new EDIE subcommittee will be working. There's still quite a bit more fine-tuning to do in that respect, and we had a good discussion around using a QI approach, the need to prioritise the priorities, to quote Sue's phrase from earlier. But the point is that EDI can't just be an afterthought. We need to ensure that those principles of equality, diversity, inclusion, equity run all the way through the work that we're doing. And people might feel a little cynical about why we're doing this now. Perhaps there might be a suspicion that this is just a response to the CQC feedback, but I think there is a genuine recognition that we need to do better in this area for our people and ultimately our patients. Just one final point I wanted to make before I hand over to Naomi. As Scott mentioned earlier, we do just have over a week before the National Staff Survey closes. And as Scott said, we currently have a response rate of around 45.5%. I know that's not earth-shattering. It's better than the final figure we had last year, but it falls short of the target we're aiming for. So I hope there will continue to be a concerted effort with that. But I did want to take the opportunity to thank everyone who has worked so hard to raise awareness of the importance of completing those surveys. We do pay close attention to the feedback from the staff survey, although I want to stress that we absolutely don't have the ability to see what individuals have said. The survey is anonymous, but we need our staff to take a few minutes out to complete them so that we can listen, so that we can learn and ultimately try to improve. Thank you.
Thank you, Bina. Before I move to Naomi, let's do the housekeeping. You, and I know your committee, are proposing a name change from Workforce Committee to the People and Culture Committee. Board would need to agree that. So can we now do that now, please? Does board agree to the change of that board committee? There's nods all round. Nobody against? There we are. It is now the People and Culture Committee, and I know Jill will ensure that the terms of reference are amended to reflect that. And thank you, Vina, for your eloquence in why it's important to do that and the other things that you raised. Naomi.
Yeah. That's cool. Apologies, Chair, we're just in the same room. I just wanted to jump in quickly on one point there. Staff survey is fantastic. Everybody's filling it in. But the really, really important part of this is that listening, learning, improve bit. I just really want to get that message out to staff that those feedback that they are providing, there will be dedicated and specific plans built against their feedback. There is a little bit of fatigue in terms of surveys within the services. So I just really want to on record. We've heard that we're reducing the number of pulse surveys from 6 to 3, and we will be doing specific focus plans based upon staff feedback. Thank you.
Yeah, thanks, Scott. And I know Sue and the comms team need to ensure that message gets out there. It's not an easy thing, but fingers crossed to get a better return rate over the next, was it 9 days? Naomi.
Thanks, Mark. So I'm just going to concentrate on the kind of key risks that are related to the workforce piece. So the first one is about the arise and the failure to deliver objectives. So I think Vina's covered this mainly in terms of that is why we're having this reset. So I think it's acknowledged there needs to be a real focus on key areas and key objectives and some tangible outcomes. And I think previously a lot of work has ended up being put under this space that has meant there hasn't really been able to be that really clear focus. And if I give one example of that, the recruitment part on nursing, we were looking at getting to our 3% vacancy rate in nursing as a whole. And if we look at our mental health nursing, which is currently about 19% vacancy rate, compared to physical health, which is about 7%, there really needs to be a review of where does that kind of an effort and resources need to go in initially to have the biggest impact, and which leads on to the risk about vacancies, which has been reviewed to be a bit more specific in terms of where the highest area of risk is, which is within mental health at the moment. So the culture, EDIE and attraction and retention subgroup will all be very much linked. They're not three completely separate pieces of work, and the chairs of those meetings will have pre-meetings and we'll make sure that all of those pieces of work are linked together. But it will give us the opportunity to look at some real focused and local interventions, and some of that is about, you know, within areas, there's areas where retention is better than others. Well, what is it there that they're doing? What initiatives is it they've got that maybe we don't have elsewhere? There's evidence that some people internally move and go somewhere else within the trust, so why are they being attracted to those areas? So it's really deep diving on some of that work and looking at some real kind of innovative solutions, particularly around our recruitment, to how we can actually do that in a better way and try and attract a wider pool. And in terms of just touching on retention, in the report it talks about the leaver discussions, which are really important, but it's also pulling in how are we actually using that data and taking those themes and making sure that that is embedded and integrated through the integrated governance route, and we're actually taking action on those.
Okay, thank you. I think we all accept the workforce. The people.
Oh, sorry.
Oh, Natalie,
we're back.
Are you frozen? You back again? Are you?
Oh, am I back?
Yeah, carry on. Yeah.
Okay. So in terms of the wellbeing risk, I think one of the key things here is going to be the resolution approach and really how we deal with our staff in a compassionate way, and some of the application of our policies and processes in a compassionate way to assist with wellbeing. We've got training, we've mentioned the Leading Together training. We're also looking at specific training on sickness and wellbeing, looking at our policies. The People Promise managers are doing a lot of work on reasonable adjustments and how we link in with the system on some of those approaches to reasonable adjustments, and to our appraisals, so increasing the quality of our appraisals as well as just the uptake. And then the last point on that is the freedom to speak up. So we've recognised in the report that the number of people reporting has gone up, which in some ways is a positive thing to say people are feeling able to speak up. But we are carefully monitoring that, because hopefully that will then start going down when issues have been dealt with. And also we're also monitoring about, do people feel confident that when they did speak up the appropriate action was taken and we actually did address those issues. So I think that's all for me.
Okay, thank you, Naomi. That report, and I know you would have all read it, it contains a huge amount of information on various initiatives and aspects that Vina's committees overseeing and seeking assurance on. It's a difficult arena. We know that, but I can just wholeheartedly say keep going. Just keep going, because it's fundamental and underpins everything that we do. Does anybody have any questions of Vina or Naomi or indeed Natalie or anybody else with regard to the workforce side of things? Sorry, I should say people and culture now. Vina, my apologies. The people and culture side of things. No? Okay, I think that reflects the breadth and detail of the report that came forward. But of course, any questions, I'm sure Naomi and Vina be available, and also any suggestions, because I know Vina's changing things, and we've put a structural change in with regard to the 3 subcommittees to the committee. I suspect any suggestions for improvement will be very welcome by Vina. Okay, thank you. Can we note that those 2 workforce reports then, please? Oh, sorry, there's one thing I did have. This isn't for Natalie. Sorry, I've got it on my notes. I've just realised somewhere in that report it mentions increasing staff on Pershore, and it's inherent that we agree that. But I think we're just agreeing for it to go into the bid process, are we? For budgets for next year, we agree it's needed, but how it's to be funded is a discussion to be had in the normal process. Am I right in saying that?
Yeah, absolutely, Mark. Sorry, this is the 6 monthly Safer Staffing report that needs to come to board. So if I can just do a really quick summary for our community hospital inpatient wards. There is definitely an increased acuity that's mainly manageable within our current staffing levels, with a watch and wait at Malvern, which is where we have our bariatric beds, but a need at Pershore, which is identified particularly on a twilight shift, which is common with dementia and delirium patients that deteriorate as the day goes on. They have a sustained need. So there's a request for a healthcare support worker, an additional healthcare support worker every day at that time. So yeah, we're just asking for that to be supported, and we'll then take that through the Trust's internal processes. And for mental health, you'll see there's quite a lot of detail around needs that might have been identified, but there's significant pieces of work happening across most of our mental health units, which mean at the moment they are just watch and waits. So we're trying a couple of QI projects, for example, across the rehabilitation to firm up the fact they only have 1 registered mental health nurse overnight. So there's no request for substantive changes to establishment at this point. There's another significant piece of work around the establishments look safe when we review them, but actually we know for the acute wards they use over and above those numbers virtually every single day. So there's a deeper dive going on in understanding that, because obviously that significantly impacts on our use of temporary staffing, which isn't ideal from a financial or a quality perspective. So there's a number of pieces of work, but nothing that we're asking board to change today.
I think very diplomatically put, I think you're telling us, but you can anticipate something coming forward in the future because of what you've just said.
Yeah, potentially. They are watch and waits, so we need to do some more work.
Okay, thank you. So with that caveat around that, can we accept Vina's report, for want of a better term, Naomi's report, and Natalie's report, and within Natalie's report, an acceptance of the need for the twilight shift of HCA within the Pershore ward? Yep, all accepted. Thank you very much indeed. Thank you for all of those. They're key underpinning aspects of our trust, and they're very, very difficult, but we continue to address them. Thank you. So if we move on then to finance performance now. I don't think Biraj is with us, and even if he was, I suspect he couldn't speak because I know he's not a well man at the moment. So I'm not quite sure how we're going to do this. I know Martin's in the arena and Denise is in the arena. So between the two of you, if you could take these reports, please.
Yeah. So thanks, Mark. I'll start off and then hand over very quickly to Denise. But I want to start with I'll obviously take the Finance and Performance Committee report as read, but there's one obvious thing about our Finance and Performance Committee report in the executive summary, it doesn't mention finance, and that is because we are on target around finance and the CIP programme, and I don't want to overlook it in terms of taking it for granted. We don't take it for granted, and I know that is a huge effort from everyone on this table and around this table, and the teams. It's not doesn't sort of happen in finance, it happens across the organisation. So thank you for that. long may it continue, that we can then focus our efforts around the performance issues that we've got, most of which we've picked up. Particularly Matthew has picked up most of those in the operations review, particularly around out of area placements, and some new ones we've got coming in around talking therapies and the older adult mental health acute discharges. We are focused on those, and we are addressing the issues associated with those. So I wanted to simply refer to some of the forward-looking risks that we're addressing through the committee. Sue has already mentioned the review we're doing around capacity and capability, so that we maintain focus on the recovery plans, but also in addressing the trust objectives, and that's a big balancing act that we need to do. Secondly, is around a big focus around agency costs. That is part and parcel of all the national objectives for this year. Whilst we are on target, and I don't underestimate the amount of work that's gone in to deliver our agency reduction this year, there is still more to do, and the targets, as you might expect, get ever increasingly challenging. Therefore, we are highlighting a risk around that, making sure that we maintain that focus to achieve that trajectory, both for the end of this year, but then going on into next year, where the targets go down to 3.2% from the 3.7% we've got this year. And then the third area that I want to highlight is a looking at how we improve the data capture and information provision to our teams, so that they are better enabled to act proactively on performance issues as they go off. There's some areas where we still have to look quite a lot into. It means quite a lot of detailed analysis rather than being put up front to our teams as you need to look here and need to address here. So that's a third area where we are looking at helping to support our teams to be more proactive with the right data, recognising the challenges we've got with resource and constraints when we're implementing new EPRs. So that's all I wanted to raise, and I'll hand over to Denise to go into more details around the performance report and finance report.
Okay. Thanks, Martin. Okay, so just looking at the performance report, so what you have in front of you is month 6. It was noted at F&P that nationally the mental health metrics are under a lot of scrutiny. Robert mentioned it earlier on. So this is impacting us at a regional level, and within the West Midlands, most systems are struggling. And noted that the ICS, our local ICS, are dropping towards the bottom of the list. Saying that whilst performance is reported at system level, NHS Midlands are looking at providers for assurance and improvement. So, so the focus, really is on us as an organisation. Trust Board will be well cited on 2 long-standing areas of concerns, which is the talking therapies, completed course of treatment, and the dementia diagnosis rates. However, what we have now, in addition to those, are 5 other areas of performance that we're slipping and require immediate attention. The inappropriate out of area that Matthew gave a detailed feedback on, perinatal access, CYP, mental health access, talking therapies, which is the reliable recovery, and SMI, physical health checks. I'm just going to go through a couple of those. Perinatal then, so the rolling 12-month target has slightly underperforming. It's about 6 to 8 patients a month since April. So we discussed that at the F&P committee. There is a robust action plan in place, and this has over-delivered during October, so that's month 7, and we are on track to recover the rolling 12-month position by March 25. Just looking at the CYP mental health access, again, a recovery plan is in place. We are starting to see progress in the trusts element of the plan. The number of CYP accessing services increased in September by nearly 200, which actually is in line with the recovery trajectory. And the system-wide plan was ahead of trajectory as at September. Activity from other partners and providers starts to feed also into the national reporting. So this is, again, a rolling 12-month target. The improvements will take time to build, but the system, is on track to recover poor performance by June 25 next year. Talking therapies, reliable recovery. The Trust has achieved the target 4 months out of the 7, and the service manager reports that the reason for the missed targets in 3 of those months is due to the complexity of presentations, as the service has aligned to the national inclusion criteria, i.e. seeing more complex patients than previously. There was a recovery plan presented to F&P in November, and the trajectory is actually the processes in place to support recovery will be in place and delivering by March 25. Just picking up SMI physical health checks, the system target has previously been consistently achieved. However, the ICB reports there is a current coding issue within the data, and that's linked to a change in data source. So the data is now going to be pulled directly through the GP EMIS system rather than being submitted by the ICB, and they're hopeful that coding issue will resolve by March 25. And then just the last thing for the performance was the recovery plan for the older adults, length stay over 90 days. A recovery plan was presented to F&P in response to the breaches. The recovery plan was not approved and just requires further development in terms of clear actions and changes going forward. And that recovery plan will be presented to January 25 committee. That's what I wanted to highlight for the performance report.
Thank you, Denise. Before we move on to finance, I'll pause there and see if there are any questions around performance and the committee report from Martin on behalf of Bede. I know that most of those things, if not all of them, we've been through in our operational report and our strategic priorities, which is the intention. Any questions at all? We do appear to be on the areas, and Denise has given a good explanation. And I personally am pleased to see when a recovery plan is pushed back because it hasn't got firm enough or detailed enough actions that are quite clear and explicit, and that's a mark of success, I think, actually, in terms of ensuring our governance is correct. So, okay, thank you. Can we note those 2 reports then, please? Thank you, and we'll move on to the finance report. Denise.
Okay, thank you, Chair. The month 6 report presented. I can confirm the Trust has delivered a break-even position, which is in line with plan, and we are forecast to deliver a planned break-even position. That's not to say this is easy, as you alluded to earlier. The run rate did decrease slightly from the previous month. However, we do know there is a substantial increase to our run rate, particularly our paid costs in month 7 for the pay award and the backdated elements. However, I'm happy to note that this is fully funded and will be offset by income. So previously, we were concerned there might be a risk of not having enough income to support the pay awards, but that has now been resolved. The Trust has reduced its agency spend by 85k from the previous month, but we do continue to breach the national 3.2% of the pay bill. We are making good progress. Year to date, we are under plan. However, as Martin said, the plan does decrease over the next 6 months, and there is there is an agency reduction programme board in place. There's a lot of good work taking place, and we're continually monitoring this. But we have highlighted a risk that we may not achieve the target. Now, the consequences of that is, I'm not sure what the national team will view, because the agency is under a lot of scrutiny. Financially, the sums that we're talking about financially, that they shouldn't impact on us achieving our break-even position. But again, it's the perception from the national team if we do miss that target. Just to say, the Trust, we are making good progress with our efficiencies, and we are slightly ahead of plan. We do keep a continuous review of those. A couple have slipped, but we've re-looked at those, and we're confident that they will get back on plan as soon as possible. And just one thing around the report on our capital programme, when you look at our year-to-date position, we are slightly behind plan, and then that is due to the 3 tenders that I mentioned earlier on: the Aikenbury car park, the MIU at Pouch, and the mental health UEC at Stonebow. They are all in their final stages of procurement. There's no risk associated with those schemes, and we are confident that we will spend the full capital allocation in this financial year. Thank you.
Thank you, Denise, and broadly a very pleasing report in most difficult contexts. And as Robert reminded us earlier in the meeting, next year will be even worse. But congratulations to everybody on this screen, because it's everybody on this screen that oversees and controls the finances. So thank you for what you do. Any questions, anybody? Denise, you've got a question of yourself?
Yes, sorry, I just wanted to follow up. Sorry, I meant to say this. Financial planning for 25-26, we are starting to look at this at an ICS system level. As Robert said, we don't have any guidance at the moment, but what we do have are a suite of ICS financial principles and assumptions that we are using. We're currently working up our high-level plans for next year. We are only looking at a 1-year plan at this stage. And we will be coming to Trust Board in December to present that. And we're also presenting at the ICS Finance Committee in December as well. So work is well underway.
Thank you, Denise. I look forward. Does anybody have any questions around any of the financial information set out in the paper, which is all very clear? No? Okay, can we note Denise's paper, please? And thank you, Denise. I know the work behind the scenes you and your team do to make sure that we get the correct information on it in a timely fashion is not always seen, but it is in this Trust with you and your team. So thank you very much indeed. That report being noted, if we could move on then to Martin, report on the Audit Committee, please.
Yes, thank you, Mark. I'll take the paper as read, and there's 3 things I just wanted to bring to the attention of the board that were key areas of discussion. One is around our external audit, and you'll be aware that we had a modified audit report last year in relation to the value for money report and the ongoing work associated with the improvement plan and the value for money. We have been pressing our external auditors to understand exactly how they're going to assess that in the upcoming audit, which will be through their interim audit in February, and then going into next year, that we are how they're going to look at that in the absence, potential absence of a revisit from CQC. We haven't yet had an answer to that, but it's an area that we are focused on and making sure that they have the right processes in place to hopefully move us off a modified audit report in relation to the value for money. The other 2 areas that I wanted to pick up are in relation to the internal audit reports and a new process we have in the Audit Committee, that where a internal audit report has less than significant assurance, the lead executive comes to the Audit Committee to confirm what the action plan is and make sure that we are assured that the action plan is on track and the resources are there in order to be able to resolve the issues. The two we had this time were in relation to employee relations, which is very tied up with the development of the resolution policy and the implementation of the resolution policy. That has now been recognised as a specific risk raised in the BAF and the risk registers that we talked about earlier. Not in terms of the, we have a solid action plan to deliver that. The question is about the timescales for delivering that. So the timescales of which we will deliver it perhaps still different from what was in the internal audit response. We recognise that the key is to get it right and to implement it effectively with through a proper process rather than implement it quickly and then have to revisit. So we're absolutely focused on that. And then the second area, Matthew came to talk to us around the transition from CAMHS to adult mental health, and the so I'll just look at my notes. The key issues that we will get, whilst the policy is broadly adequate, some of the areas around compliance and governance and making sure that it goes through an integrated governance process, and the triangulation of that sort of triumvirate structure, that we're picking up all the different angles associated with that, and Matthew explained how that was going to work effectively. But alongside that, it also picks out again, one of the historic differences we've got between the way it operates in Herefordshire and Worcestershire, and the moves to get the commissioning arrangements aligned so that we actually can move to an integrated approach for CAMHS and have a unified service across Herefordshire and Worcestershire. Those are two areas I wanted to bring to the attention of the board, and say we will keep an eye on it. They will come through the audit committee to make sure that we are progressing and delivering against the action plans that we set, but we have solid action plans in relation to those. And then the final area I wanted to bring is that we are now looking at, and we have a meeting next week around internal audit to say where are the key areas that we need to focus on for internal audit next year, with the sign-off from each of the committee chairs to make sure we are addressing the areas where we have the most risk associated with non-compliance or improvement, to make sure that we continue to drive the progress around risk areas.
Thank you, Martin. It's pleasing to see the grip that you and your committee has around these issues. Thank you. Any questions at all for Martin? In which case, can we note that report, please? Thank you, Martin. And we move on to Mental Health Joint Collab Committee. Carol. Sorry, my mistake. I'm jumping ahead. Sue,
yes, Sue
Mental
first.
Health Ledge Committee.
Thank you. My power is diminishing, so I was worried that I was going to lose power before I spoke. So we did some training. We did some training in PCREF and in the Adult Mental Health Rehabilitation Redesign. We talked a little bit about the high number of Section 3 patients, and many of the reasons for that were similar to the ones that Matthew outlined earlier about the difficulties of patient flow, many of which are outside our control. We heard that the individual patient advisor, which had been piloted in Hillcrest alongside the IMHA, had actually been rolled out across our mental health wards. And we plan that next meeting, we're going to look at the risk safety tool, which is replacing GRIST. And we're also going to learn more about ASD, which again is a feature of this meeting. And that's it.
Thank you, Sue. And of course, in December, we're going to have a good look at the Mental Health Act and some training and refresher from Jill and the team, which will be really useful and pertains obviously to your committee. Thank you. Can we note Sue's report? Thank you very much, and we can now move on to the Mental Health Collab Committee and Carol.
Thank you, Mark. And again, I wasn't planning to go through this in detail because I think we've already talked about the performance elements under lots of different headings. I think there's a couple of things that it is worth pulling out, though. The SMS Crisis Support Options Appraisal, I think the summary of this is that it's finding digital means of being able to support more young people in a better way. And therefore, from that point of view, I really welcome this, but I also welcome the scrutiny by the committee because it was able to ask for some additional assurance before we actually go ahead with that particular commissioning exercise. I think we've had a lot of discussion about the Adult Mental Health Community Services Review, and I think really we will be looking at this in more detail at the Mental Health Joint Committee in the new year, as we heard from Robert. It's very much part of that sort of governance line, and I would quite like to circulate that date to any of you who might be willing to or able to attend, because I think it really will allow some of that conversation at looking at what we need to be doing alongside a whole range of system partners rather than just focusing on the trust. So perhaps we can make it an action and we'll let you know when that meeting is going to happen. Other than that, I think the main point here is there is a review, that's in the paper, it's really for information, that there is a review of the Mental Health Joint Committee underway at the moment, really just to make sure that we're very clear about our purpose. A view I have heard expressed already is that it is not the time to be taking away anything that is putting focus on mental health. So I'm sure that will be the sort of thing that we feed in the future. But again, any input anybody would like to provide on that would be really good. And just a really, I don't like not having any achievements at all there. So one very small achievement is that the ICB board was held yesterday, and that we are pretty much using the same report for the two meetings, which I think shows consistency across the committee, but also trying to save a little bit of work for some of our colleagues. Thank you.
Thank you, Carol. And on that review, I have an appointment booked in. I'll be interviewed with regard to the review on the Mental Health Collab Committee, and I'm sure that review will be used to promote discussions initially at the most senior level, involve yourself, Carol, about the future of the Collab Committee and how it can deliver what we think it should deliver. So I think that work is very well founded.
Thank you.
Can we note the content of Carol's report? Thank you very much indeed. Which then takes us to the annual government statement, the 6-month review, which is set out by Jill there. Oh, sorry, no, I'm getting ahead of myself as the person that's supposed to be delivering the Remuneration Committee report. I'll take it as read. The only thing I'll say to you, you'll notice on there some redundancies to give you assurance that the committee received assurance that everything that was possible to do to avoid redundancies was done, and the reason that the redundancies came about is because of the specialist nature of the team that were being disbanded because of the decommissioning of this service by partners. But everything was looked at to try and make it so we didn't have redundancies. There are a number of, I think broadly we started off maybe 10 to a dozen staff, and we got down to only 4 that needed to be made redundant, unfortunately, although I think they understood it. Apart from that, if anybody got any questions at all on that report? No, thank you. If you could take that as noted. And then Jill, annual government statement review, please.
Yes, so people will be familiar that we conduct a review of our annual governance arrangements, and the annual governance statement is in a prescribed format that we're required to complete annually. It forms part of our end of year review and is part of our annual report. As a matter of good practice, we undertake a 6-monthly review, and this is the review there. I will apologise that the report is longer than what we're now aiming for board papers, but due to the prescribed nature of the content, the only way I could get it under 10 pages would be if I put it in very small font. So I do apologise for the length, but I think it actually sets out a really comprehensive view of our governance arrangements, with particular emphasis on our quality governance and how we ensure that we're providing safe services, and obviously it covers off the requirements to operate efficiently and effectively. The report is there before you. I'm happy to take any questions or expand on any areas if anybody's got any queries about.
Thank you, Jill. It certainly sort of sets out how we do stuff around here, which is, if you haven't studied the detail of it, it does exactly that. Anybody any questions for Jill at all? And it's a 6-monthly review. No, thank you very much. We can note that report, which then moves us on to reports considered elsewhere. So these, you can see from the agenda, you can see where they've been considered. And there are some quite important reports there that have been looked at through our committee structure, and they're obviously available to anybody that wasn't on those particular committees. So if you need access to them, you'll certainly find them on Diligence, or indeed if you need some directions, then Jill will point you in that direction. If there's nothing on that, I don't think there is. There's a couple of deeds, one deed of variation, one renewal lease. The renewal lease is just a straightforward carrying on what we're doing there. Can somebody tell me what the deed of variation is on the Droitwich Medical Centre, please? Jill.
It's additional space at Droitwich, which became available.
For which team is that, Robert, please?
It's the community neighbourhood team.
Okay, thank you. If we can note those, and then pleased to report that Dr. Jonathan Packer, consultant psychiatrist in older adult community mental health, is joining us, which is great, because as we know, recruiting substantive psychiatrists is not the easiest thing to do, especially in Hereford, to be honest, because of the sparse nature and the small population in that area. So a particular welcome to Dr. Packer. I hope everything is set for him when he comes and he's got everything he needs, and I'm sure John and the team will ensure that happens. Which takes us to any other business, but before we get there, I just check with colleagues, is there anything we've heard today in our meeting that makes us think we need to add to a risk, delete a risk, or add anything to our board assurance framework? Is there anything that's come up that we don't think is contained? And usually for me, I didn't spot anything. If there's nothing else, then okay, we will keep an eye on that to make sure that we are capturing our discussions within our risks and priorities. Takes us to the date of the next meeting is the 23rd of January, which sort of means there's Christmas between now and then, so happy Christmas. I know that we're coming together to meet at for a 1:30 kick-off, I think. No, what time, Jill? Remind me, what time are we kicking off?
1:15.
She's a hard taskmaster.
No.
Yeah. So 1:15 start for our private session this afternoon in King's Court too. But before I close today, one of the things that's brought out today, I think one is the reports are better and they're more targeted at the real areas of problem that we got. And thank you for the candid nature of them, as I said before. But because as a board, and indeed as an executive team, you are used to just dealing with the problems and the issues and all the difficulties, because that's your and our job. And sometimes it can be easy to forget the amount of fantastic staff that we got, day in, day out, night in, night out, doing fantastic work that we heard from our patient story was just one small example across the whole piece. And we saw it at our leadership improvement event last week. And I just want us to remember that the vast majority of what's going on is brilliant work, delivering for our patients, delivering for our staff, and we'll see far more of it on Friday evening, tomorrow evening, when we have our annual staff awards, where we try and recognise, we do our best to recognise the fantastic work that's going on. So on that note, I'll finish and I will see you all for a 1:15 kick-off in King's Court.